Good afternoon and welcome to United TV. This is Kemal Erkan. Our Bariatric Friday event, as everyone is following us, they already know by every Friday 3 p.m. Today is June 13th. And we are going to actually have a little detour and we are going to discuss general surgery. And Dr. Mike Peters from CRIAS is going to be joining me and we are going to discuss different general surgery conditions and understanding them and how we can actually identify some of these early on and how early identification diagnosis can help and prevent costly surgeries. So knowing that all these things start small with like mild abdominal pain that can escalate very quickly and then can become a major problem. And that's why we are here at CRIAS and American Surgery Center to make things better for our patients and the population that we live in. So I'm going to welcome Dr. Peters. Dr. Peters, how are you doing?
I'm well, Kemal. Thank you for the invitation.
Of course. We now do this on a regular basis, and bariatric is our main focus. And what happens is we also do a lot of general surgery cases. So we did one session with Dr. Gail Wynn, and it got a lot of good positive feedback. And I thought it would be good to actually go over some of those procedures again to educate our patient population. And so we are going to discuss some of the general surgery cases. So you were in our surgery center today.
Yes, I was busy from about 8:30 this morning in the surgery center after rounding at one of the hospitals and actually followed Dr. Wynn after some of her procedures. I did general surgery all day today, no bariatric operations. So there were endoscopies, there was gallbladder surgery, and hernia surgeries were all involved in my day today.
So we can start with hernia if you would like. So if you can actually tell us what hernia is, and I have some follow-up questions after that.
Fantastic. So if you were a patient and you came to see me for a hernia, it's typically found by self-examination or a visit from a family doctor, and a physical exam notices an asymmetry of the body somewhere, typically a bulge. And what you might experience as a person who's having or suffering from a hernia is a burning or a discomfort. You might see a bulge that when you were to lay back at rest, the bulge goes away. I tell patients that a hernia is a hole. Sometimes they ask if there's a medicine that will fix it, or if they can change their diet or stop doing what they're doing. And I say, well, a hole does not repair itself. It's akin to a pothole. It's a certain size, but if you keep driving over that pothole, it will get bigger. And this hole has resulted from a behavior of yours, and it's likely that you're going to continue that behavior, and the hole will get larger. Does it need to be fixed? Well, I'm a surgeon. I like to do surgery, yes, but we have to weigh the cost and the benefits of any intervention because everything has risk. But immediately, should it be fixed? And it's really a question of symptomaticity, meaning does it hurt? Is the bulge painful at rest? Is the bulge painful when you work? Is there something in the bulge that is concerning, a piece of small bowel rather than a small piece of fat? Because all of these go into the evaluation and whether we should get you quickly to the operating room or whether we can delay treatment. Aside from medical factors, a patient who is 92 and a hernia is discovered incidentally, well, what degree of physical activity are they going through every day? Should we really operate on 92, or couldn't we manage that conservatively? But typically a hernia needs to be fixed because, as I said, it does get larger with time.
So now distinguishing from the one that can wait versus needs to be urgently done, I think that probably depending on the person's age, gender. So because I remember a couple of my friends who had hernia and they just were going through the pain because they didn't want to have the surgery. But if it was maybe a patient over 50, female, maybe they couldn't handle that pain. And I'm not being sexist. I'm just giving an example. So one of them was my barber, and he just like 3 months he didn't have the surgery, and then it got complicated for him.
Yeah.
So, but he was going through the pain, and I'm like, why would you do this to yourself? But again, there's a lot of education issues there too. So, can the patient decide on waiting or not waiting? Are there anything that they should be looking for?
Well, obviously, a patient's decision making goes into the process. However, the patient needs to be educated and informed that someone like your barber, who stands all day,
Right.
the weight of the abdomen wears on that hole like a pothole. So they're driving over that pothole every time they go to work. It's going to get larger quickly, and if they're feeling pain, the pain will get worse. In that situation, it's better to intervene early. You can do a minimally invasive procedure. You can do it rather quickly as an outpatient and recover very nicely. There would obviously be some delay getting back to work. It's not that comfortable. I've had a hernia, I know that. But now they've created a large pothole, a large hernia, and that's going to need a larger intervention, greater element of repair and muscular tension involved, and there's certainly going to be a little more discomfort. So the degree to which a patient can wait, that really has to be talked through with your surgeon, because as I said, a 92-year-old probably doesn't even need the surgery, and their waiting will be indefinite. A 20-year-old with a small surgery, better to take care of it early than later. They're more active, they're doing more things, their activity level is variable. They might be at work one day, they might be bungee cord jumping on the weekend and then get into real trouble. So each of these factors plays into it, and it's individualized.
So, Dr. Peters, the surgical techniques, what factors influence your choice when it comes to hernia?
Well, there's several things that go into weighing how I should repair this patient's hernia. There are essentially three techniques. There's the laparoscopic technique, the robotic-assisted laparoscopic technique, and old school open surgery repair with muscular closure and mesh. And mesh is utilized for all of these repairs. So in a patient who has a significant amount of comorbidities, maybe we'd like to avoid general anesthesia because it presents a very high risk in certain patient populations. Older patients, it can accelerate dementia. Cardiac patients, general anesthesia elevates risk for another coronary event. Maybe we can do this with just some local anesthesia and some sedation, much like you would get for a colonoscopy procedure. That's a safer way to do the procedure, albeit the patient will be sore afterward. The laparoscopic approach and the open approach have the same outcomes after 3 weeks. So an open approach will be safer for certain patient population when they don't need as much anesthesia. And if a hernia is very large, actually, sometimes the open approach is preferred because simply getting what is ever stuck in that hernia out can be challenging laparoscopically. So again, it depends on the patient's presentation.
And when we were going through remember in the old days with surgeons for emergency care, I spent a lot of time with you guys, with Dr. Erkan, and better understanding the surgical techniques and how open was the only option for a long time. And then laparoscopy came, and then the robotic, and then the big difference between the two, at least from non-surgeon standpoint, is the movement that we have. So then laparoscopy goes the opposite way, like the mirror, and the robotic is following. And all those were kind of making sense, but then it really depends on the surgeon's training also. And also, if things are not going well, then the surgeon should be comfortable doing the open surgery, right?
Absolutely. As a surgeon who is an early adopter of laparoscopy and has done a fellowship in laparoscopy, I'm specialty trained in that. So it's primary thought in my mind. There are still surgeons around who are now older than me, not much older. I seem to have gotten older myself. I don't know how that happened. But they still will do an open repair because that's their familiarity. That's what they know. That's what they've been trained in. And it's not that they see laparoscopy as a lesser operation. It's just that they don't know how to do it. So these decisions do play into it. But again, operating early, taking care of a patient when their symptoms first arise, the laparoscopic approach is probably a better technique for a faster recovery, lesser pain overall, and the ability to get it managed and behind you quickly can't be understated.
Now, our next surgery is gallbladder disease, gallbladder surgery, and this is one of the most common general surgeries. And
After hernia.
most of them are done in the emergency settings, unfortunately. And because of our, other entities that we did business with, we know firsthand how these things are being processed in different hospitals. So, what is a gallbladder disease? And I have some follow-up questions.
Of course. So, pretend you're a patient who's come to me. You have some discomfort in your upper abdomen. Maybe it's a little more to the right side. Sometimes the pain awakens you. Sometimes you notice it after you have a meal. Sometimes it'll radiate to your back. You'll feel bloated, gassy. All of these are common complaints from a gallbladder disease. The gallbladder is a pump. And I tell my patients it's a pump that responds to the ingestion of fatty food. Not an immoral amount of fat. I can say it's just, hamburger, pork chop, even salmon has a good amount of fat in it, butter. That will set off a gallbladder. Its job is to pump bile from the vesicle into the duct, into the intestines, and help digest that food. So you're asking it to be a muscular contraction. If that muscular contraction is impaired, either by dysfunction of the muscle itself or obstructed downstream by a stone, the gallbladder becomes very distended. And as it distends, the blood vessels will efface. If you were to take a garden hose and stretch it, it gets very thin. These blood vessels carry oxygen. So now the gallbladder itself is not getting any oxygen, and you're suffering literally a gallbladder attack along the lines of a heart attack. This is very painful. So at that point, a single attack typically is followed by multiple attacks later in life, and it's not something you can really manage with diet long term. It's bound to happen again and again. So your family doctor may at that point refer you to a surgeon to be evaluated for gallbladder removal. And that's where the two of you will meet and discuss, what is the best course of action at that time.
Sure. Now, a lot of, patients that we know who are going through this, but then I do like to give examples from my family and friends, barbers too. So barber is no longer my barber, by the way. So a lot of people with the gallbladder issues, they think that it can be delayed. It can be an elective surgery, but in cases, many of them done in the emergency settings. So now, when is the time to do the surgery? If let's say one of my sisters, so I was going to use yours, but I'm going to use mine just to be safe. 60-year-old, and she's younger than that, but if she has this diagnosis already in place, when is the right time for the surgery?
So if a patient ends up in an emergency room, this pain has been significant enough for them to unwillingly go to a large administrative care facility, pay a very large copay, and get into a hospital bed and submit themselves to testing. That is significant pain. It deserves a full evaluation with blood work and an ultrasound and the appropriate testing, because it can lead to sepsis and you can become very sick. So that patient is in the right place. If that patient's pain does not resolve within 2 or 3 hours from being in that emergency room, the best course of action is to get that gallbladder out within 24 hours. The gallbladder is sick. It's not likely to get unsick, and it would make them feel worse if they were to be discharged with some Tylenol or pain medication. That would mask the pain and they would likely get sicker. Now, if a patient has sought your attention in the office, or they've had an ER visit where they were sick and in pain for 30 minutes, and it seemed to pass, they may have passed a stone. And that passing a stone is painful, whether it's a kidney stone or a gallstone. And that acute situation has resolved, and then they can be managed as an outpatient. So again, it's about symptomaticity. If they are acutely symptomatic and sick, it needs to come out typically within 24 hours. The literature says that's the best timing. If they get unsick or their symptoms resolve within 3 to 6 hours of admission or of observation, then they can be discharged safely. And then the gallbladder should be taken out electively at a later date. Any elective procedure has less complications than a procedure done from the emergency room or in a hospital setting.
That's kind of really the important thing. So if it's elective versus if it's in the urgent setting, things are all different. So, and I'm going to come back to this because I have one patient example that's recent, and I'm hoping that we can talk about that a little bit. And some of my follow-up questions will be related to this. So now our third one is my not one of my fan, kind of like the word that I'm trying to, like, I cannot pronounce it properly, especially in the live settings. Diverticulitis, right?
Well done, yeah.
Well done. So I have to focus. So although it's a very difficult one to pronounce, this is also very common.
Diverticulitis is very common. About 50%, well, diverticulosis is very common. About 50% of patients over the age of 50 will have some element of diverticulosis. And as I tell my patients, it's okay to have tonsils. It hurts to have tonsillitis. It's okay to have an appendix. It's not okay to have appendicitis. You can have diverticulosis, but when you get diverticulitis, you have a problem. Diverticulitis is an inflammation of the colon. Diverticulosis is, or are, small outpouchings of the colonic wall. It's a muscle, so it's almost like a little hernia along the muscle wall of the colon. And that little outpouching serves as an eddy in a river, and things will recirculate in there. And over time, it will collect particulate, stool, vegetable matter, whatever seems to be in the fecal stream. And when that sits in that little outpouching, it'll irritate the wall of the colon. And if that irritation is enough, it can either bleed, be painful, or even perforate and cause a really significant problem. So get your colonoscopy at age 45, know your diagnoses, and if you are suffering abdominal pain, you should be evaluated by your physician, and imaging would be considered, when it's critical.
It can become a life-threatening problem if it's not
absolutely. Perforation of the colon can lead to significant outcomes like sepsis.
And also diet has a lot to do with it, right? So the amount of fiber and the water intake that we have.
Diet's a very interesting topic, and people will fight on the left and fight on the right of this. We typically blame a Western diet or a high-fat diet, too much red meat, and then we say, oh, it makes the colon work too hard because of the lack of fiber. And when the colon works too hard, you get these little hernias or outpouchings that we talked about. And that's the theory about how diverticulosis forms. Not well-founded in science, but believed to make sense in physics. Now, there is literature to say food doesn't matter. There is literature to say that what you eat matters. But in the middle is everybody agrees on fiber content. And fiber content in an adult diet is lacking in the United States. And it should be considered an addition to all meals during the day to improve colon health and decrease the incidence of diverticulosis overall. Regardless, if the diverticulosis has this situation where the stool gets impacted and then inflamed, diverticulitis is not a joke. It needs to be dealt with by the doctor, and in the emergent setting can be really fraught with complications.
Yep, absolutely. Now, our fourth surgery type today is appendicitis, appendix, which is probably the most common general surgery? Um,
Well, hernia would be the most common general
ele-
surgery,
okay.
elective,
Hmm.
and then gallbladder's probably a combination of elective and urgent, and then appendix is what wakes me up at night, and people call me in the emergency room for, yeah.
Right. So what is appendix?
The appendix is a vestigial organ or a leftover organ, we think. It doesn't serve any function other than give general surgeons a job. However, people without an appendix
Hmm.
are known to be more prone to C. diff or Clostridium difficile type diarrhea.
Okay.
And if they do get Clostridium difficile diarrhea, they're more prone to have recurrent episodes. So it's theorized that it serves as a reservoir of native bacteria for the colon
Hmm.
that will repopulate that bacteria after illness events that cause significant evacuation of the colon, like a food poisoning
Hmm.
or a round of antibiotics that might cause you some diarrhea, loose stools. Be that as it may, the appendix is a cul-de-sac or a blind end on the end of the colon, and just like a large diverticuli, stool can get down in there. The particulate can sediment out and form a stone or fecalith. If that fecalith then impacts the long tubular cul-de-sac, the mucus that's secreted from the appendix cannot get out. The appendix will start to swell, and this is your classic appendicitis, where you get the pain down in the right lower quadrant and the fever and the feelings of nausea. And the emergency room will call me and say, hey, this gentleman meets all the criteria, or this woman meets all the criteria. We feel they need their appendix out.
And usually men in their 20s are kind of high-risk group.
That's the classic presentation in the medical school textbook teaching,
Hmm.
but I've taken a lot of appendixes out, males, females, old, young. It can happen anytime.
So I want to go back to our one of the reasons that we do these sessions, these episodes, to educate patients and in some cases even our providers. So a lot of them are watching these, and sure public get some benefit as well. Um, and you and I, we've been working together for almost 20 years, and one of the main things that we try to make a point of is, can we actually make things better for the patients? The outcome can be less painful. Outcome can be, like we don't have to open the patient. Like it can be done laparoscopically, and if it's done like you just said it very nicely, if it's done electively versus if it's done urgently, that's just two different animals. So things are going to be, complicated with the emergencies and availability of the facilities. The OR availability and all that, while you can actually, when not in every cases, but many cases, these can be done in the elective settings. So one of the patients that we had, because we have our Wednesday meetings, and I think this Wednesday it didn't happen. So because we had a lot of people were out, so I think we are going to discuss this probably next week. And it was a good point to kind of understand the system itself here. So this patient was seen in one of the big healthcare hospitals here, and it was early in May. And then patient was not operated and was given a follow-up for end of May. So there's almost 1 month delay on what needed to be done. I don't know if it was scheduled for end of May, or probably it's not, because it was a follow-up with the surgeon, outpatient follow-up. So that patient ended up in one of our hospitals on June 2nd. And it was already too late. So we could have done that case in the surgery center, but it became a big deal because it was already too late. Because one, maybe patient didn't act on it and then make a big deal out of the scheduling. Sometimes it happens, as you know. We have whole care coordination team to keep the patients on their schedule with so many different appointments on the bariatric side. But it's true for the general surgery as well. So, and as like me personally as a patient, I'm horrible. So I never follow any of or I never follow them in a timely manner. I do follow them at some point. So, and this patient could have done, like, if we were able to do it in our surgery center in the beginning of May, that patient would be home same day on the day of surgery.
Absolutely.
So now it turned out to be an open gallbladder, and then she was in the hospital for 2-3 days. And like from the patient standpoint, it's a horrible experience for something that could be done so easily. Now it's a major problem. And from the from the patient standpoint, there's a lot of deductibles and other out-of-pocket expenses. For insurance companies and for employers, they are also paying this. And I think Surgery Center, and especially with our American Surgery Center, with the partnership that we have with CRIAS, so some of these things only happens in a smaller scale. Like if it's at a huge hospital, this may not be a huge issue for them to focus on, but for us, that becomes the center of our day, the focus of our day. So like that's all we do. So just like we do more bariatric cases than any other facilities in Delaware, and we are not one of the biggest one in Delaware. We are a surgery center, so it only happens because that's our focus. And I know our surgery center has a lot of potentials, but only if this is understood by the patients and by the employers and by the payers. So, what's your take on this one? What, from the surgeon standpoint, how do you feel about that patient when they were already too late? Now,
Well, it can't be overstated that the system is overburdened. And when you're talking to a patient and they've been through the large corporate hospital system, it's slowed by its own size. And that's unfortunate because patient care needs to be expedient. We are blessed and lucky as a combination to have not only a lot of general surgeons available in our group, but also have access to the surgery center where we can get a patient in, booked, and maybe the patient has seen me, but they need it done right away. And my partner's operating that afternoon or the next day, we can get it done within 24 hours.
Right.
Whereas a corporate entity, that's not going to happen. That's a large ship. It can't be turned that quickly. We are more nimble, and again, utilizing the tools that we have, both the number of surgeons available and the surgery center, patients are going to get quicker care and avoid those emergency situations. Because not only did the patient suffer in that sense, because they got a larger incision, they had a longer recovery, the potential for extra blood loss and complications are all greater, again, with an urgent surgery and a larger incision. But that patient wondered, why didn't my operation get done laparoscopically when most of my friends who have had this same surgery got it done laparoscopically? And then it brings into question the care of their surgeon. So it hurts not only the patient, which is simply our priority, but also the doctors as well.
Well, hopefully we can identify those patients early on, which we try so hard, and with CRIAS and Surgery Center at American Surgery Center. And I know we are impacting patients' lives already on both bariatric and general surgery side, and working with United Medical ACO and working with our primary care physicians, and also making them understand what availability we have and how we are quickly able to act on certain situations. So I think their perspective also changed to these types of things. So they do follow up. The central office has a huge impact on these patient follow-ups, and I believe things are going to be better, and we want to see less urgent gallbladders, urgent hernias, and urgent of any of these surgeries wherever possible. So, well, Dr. Peters, thank you so much. So I know when you guys are doing your office hours or the surgery center hospital hours, and then coming here for these, it's important for us. And then we also appreciate for your understanding and your practical insights on these and your expertise. I know your patients love you. And then we want to come back with other topics, and hopefully we'll have you again in the future. So we covered another sessions of general surgery today, and hopefully people are benefiting from this. Please reach out to us at CRIAS and Surgery Center or any of our United Medical ACO providers if you need to escalate these issues. And we'll see you next week. Well, stay united. Bye-bye.
Thank you for the invitation.